My name is Kristen Lynn, and I am a physical therapist at the Milwaukee VA Medical Center. Today I will be presenting a project on high-intensity gait training in 3 chronic stroke survivors. Please note that these cases were developed as part of my neuro residency, which I completed at the Clement J. Zablocki VA Medical Center in Marquette University. And this is an implementation project for the ANPT's task force for the Locomotor CPG for chronic SCI, TBI, and CVA. These examples represent my clinical reasoning and are just one example of how to implement this clinical practice guideline. I have no personal disclosures, and all participants provided consent to participate. This table summarizes recommendations from the 2020 Locomotor CPG published by Hornby et al. The first row includes interventions that should be performed. This includes moderate to high intensity walking training, as well as virtual reality coupled treadmill training. Interventions that may be considered include strength training at high levels of resistance, circuit or combined training, cycling training, especially at high intensities, and virtual reality coupled balance training. Interventions that should not be performed to improve walking function include sitting and standing balance without augmented visual input, robotic assisted walking, and body weight support treadmill training with therapist assistance. In this presentation, I will show how I prioritize the interventions that should be performed, and when it was not possible to do those interventions, I used some of the ones that may be considered, and throughout my plan of cares, I avoided interventions that are not recommended. In this presentation, I'll be talking about 3 patients with chronic stroke who I treated in the outpatient setting. I would like to point out that this presentation includes video examples, and these videos were taken across a few treatment sessions with each patient. These are just examples of a few sessions. I tailored each session to meet my patient's needs and adjusted the subcomponents and my interventions to meet their goals and how they were tolerating therapy that day. For each patient, I calculated their heart rate max. I did this by taking 208 and subtracting 0.7 times their age. I subtracted 15 beats per minute if my patient was taking beta blockers to adjust for their blunted heart rate response. During high-intensity gait training, I measured my patient's heart rate to gauge intensity, and I used a polar wrist heart rate monitor pictured on this slide. For each patient, I used the subcomponents of gait as a framework for my intervention. These include limb advancement, which is foot clearance and positive step length, stance control, which is avoiding limb or trunk collapse, propulsion, which is the forward movement of center of mass, and balance, which is maintaining an upright position. For each patient, I augmented or challenged these subcomponents to help them meet their goals and progress in therapy. I did all of this while working at high intensities. Some of the barriers that I ran into were reaching and maintaining the target heart rate zone while challenging balance. I'd often find that my patients' heart rates would decrease when I was focusing on balance. Some of my patients were limited in their walking outside of therapy. This was multifactorial, maybe due to motivation, safety, or the required assistance. And there were some barriers to my PT plan of cares, these being transportation and other medical conditions. Let's start with the first case. This patient was a 70-year-old male. He was retired, he lived with his wife, and enjoyed spending time with his family. You can see his past medical history here. He had a CVA 6 to 12 months prior to presenting to outpatient physical therapy. The exact date is unknown. He had multiple lacunar infarcts, all on the left side of his brain, in the corona radiata, basal ganglia, and thalamus. On the initial eval, this was his ICF model. He had impairments in his right upper and lower extremities, including fractionation with rapid alternating movements, finger to nose, and heel to shin. His strength was grossly 4 out of 5 on the right, and he was demonstrating freezing of gait of his right lower extremity. He was needing assistance for bed mobility and standby assistance for ambulation with a walker and stairs. It was challenging for him to visit his daughter due to having to navigate stairs, and he had stairs to enter his home as well. A positive environmental factor was he lived close to the VA and was easy to make his appointments. He had low motivation to walk outside of therapy, and his wife was his primary caregiver, and she was definitely feeling some burnout when they started therapy. These were his outcome measures on evaluation. So you can see his Berg score places him at a fall risk. Gait speeds are slower, and he walked 530 feet during the 6-minute walk. His goals were to walk further, visit his daughter more easily, and walk without an assistive device. This was my FITT goal for this patient. I plan to see the patient 2 times a week for 30 minutes each session. I would like to point out that this is lower than the frequency often performed in the high-intensity gait training research. In the research for patients with stroke doing high-intensity gait training, the patients are often seen 3 to 5 times a week. Due to clinic availability and patient availability, 2 times a week was the most reasonable frequency. The intensity I was targeting was 70 to 85% heart rate max, and I planned to see the patient for 8 to 12 weeks. My intervention of choice was high-intensity gait training. I had to overcome several barriers while working with this patient, and the first was maintaining his target heart rate zone while challenging balance. I often achieved this by implementing circuits that alternated activities targeting propulsion and balance. His heart rate would go up during the propulsion activities, and it would drop during the balance, but then we would go right back to propulsion to keep him in his target heart rate zone. He demonstrated decreased right foot clearance, so we ordered him a rebound foot up, as pictured here, to assist with that. He had low motivation to walk at home, and so I recommended a pedometer. This one here costs about $15 to $20. I have found that this pedometer is moderately accurate, but I do find that it's helpful for a patient to compare their personal step counts from day to day. And I also provided a step log, and the patient's wife was very motivated by the step log to encourage the patient to be more active throughout the day. During his plan of care, this patient had a fall at home, which resulted in right knee pain. He was cleared, he had an x-ray showing no fracture, and his PCP cleared him to continue with PT. However, he was limited by the pain, which required us to hold off from walking during 2 sessions, and so during that time, I substituted the recumbent stepper at high intensities, and so I gave him a step per minute goal and measured his heart rate with the wrist monitor, and we resumed walking as soon as he was able to tolerate it. Here are the walking interventions that I implemented with this patient. The first activity is time challenges, and so here I am challenging the patient's propulsion, and I am timing him as he walks from one end of the gym to the other. And when he turns around to come back, I challenge him to beat his time from his previous repetition. So you can see here, he's walking a little bit faster than in the last clip. And then on this last rep, you can see that he's going even faster than the first 2. He was very motivated by this, and his heart rate reached 82% of his heart rate max. In the second activity here, I am challenging his limb advancement and balance. I'm having him step over these exercise cords with his leading with his right leg and using his single point cane. Notice when he was turning there, he had some mild freezing of his right lower extremity. And his heart rate is 78% of his heart rate max. This activity is weaving in and out of the exercise band. And so I am challenging his balance here, specifically with turning, because as we observed in the previous clip, he had some freezing of gait and difficulty maintaining his balance when turning. And he has a loss of balance here, requiring assistance to correct. And his heart rate is 66% of his heart rate max. So dropping in the activity where I was challenging his balance. And so I went right back into an activity to challenge his propulsion. So here he is navigating stairs. This is challenging his propulsion, some limb advancement, and his balance a little bit. He's progressed from holding onto the rail with 2 hands to only holding on with 1. And his heart rate here is 75% of his heart rate max. So this is the actual FITT that the patient completed during his plan of care. He was seen 1 to 2 times a week. Often, we had a few barriers due to scheduling conflicts or the patient being out of town, so we did our best there. We were able to achieve our goal intensity, and he was making good progress in therapy, and so his plan of care was extended because he was still doing very well. And so when I finished my residency, he was actually still being seen. And the type of intervention was high-intensity gait training with a few sessions of the recumbent stepper when he was unable to do high-intensity gait training due to knee pain. These were his outcome measures. So you can see at initial eval, a reassessment, and then the 728 ones were at the end of my residency. He met the MDC for chronic stroke for the Berg. His gait speed improved, although he did not meet the MCID, and he did meet the MCID for the 6-minute walk test. I'd also like to point out that initially he was using a 2-wheeled walker, progressed to a 4-wheeled walker, and at the last reassessment he was not using an assistive device for his gait speeds, but continued to use a 4-wheeled walker for longer distances. So this patient continues with PT 2 times a week, mainly focused on ambulation without an assistive device. During the time I worked with him, he increased his daily step count from 800 to about 3,000 steps a day, and this was just over the course of a month. So using the pedometer and step log was very effective for him in increasing his walking outside of therapy. He walked up a flight of stairs for a cookout with his family, which he was very happy about, and he was making good progress towards his goals to walk further, visit his daughter easily, and walk without an assistive device. All right, now that we've finished the first case, I'll be moving on to the second case. This patient was a 58-year-old male. You can see his past medical history here, and I would just like to point out alcohol dependence and a history of anoxic episodes related to alcohol use. This patient presented with significant ataxia, which I think was definitely influenced by these aspects of his past medical history. He lived with his friend in her apartment, and his stroke was more than 6 months prior to his outpatient physical therapy. It was chronic on imaging, but it was unclear exactly when he sustained the stroke. And the location was the right thalamus, and he had a lacunar infarct. This was his ICF model on initial evaluation. He had right greater than left upper extremity and lower extremity dysmetria, a positive rebound test, impaired balance, and ataxia. He was needing assistance for outdoor ambulation and stairs. He was sitting on the shower floor for bathing. He was unable to leave his home independently, and he had stairs to enter and exit his home, and he depended on his friend for assistance with IADLs and community mobility. These were his outcome measures at evaluation. You can see his Berg score placed him at an increased fall risk. His gait speed was on the slower end, and his 6-minute walk was 529 feet. His goals were to walk without an assistive device, walk good, and move out of his friend's home. This was this patient's FITT goal. The goal frequency was 2 times a week for 30 minutes. Once again, this is lower than what is frequently done in the research, but this frequency was selected due to clinic and patient availability. The target intensity was 70 to 85% of the patient's heart rate max. I was planning to see the patient for 12 weeks while we implemented high-intensity gait training. The most significant barrier that this patient had was ataxia limiting his cardiovascular intensity. His ataxia was so severe that it limited his motor capacity to generate propulsion and cardiovascular output to reach his target heart rate zone. In an attempt to help him increase his heart rate, I tried adding ankle weights and having him perform stairs. These tasks can increase the propulsion demands and result in an increased heart rate and therefore intensity. I would like to point out that by adding ankle weights, I was aiming to increase intensity, not to dampen his ataxia. Another barrier was that he relied on his friend for transportation, so he was only able to attend PT one time a week, even though I had initially recommended 2 times a week. He did not trust VA travel and was not willing to take that to his appointments. These clips will show some examples of walking interventions that I implemented with this patient. In this first clip here, the patient is ambulating with a narrow base quad cane. This is a challenge for his balance as he typically ambulates with a 2-wheeled walker. You can see how the ataxia is impacting his gait pattern, his speed, as well as his balance while he ambulates in this video. His heart rate was 54% of his heart rate max. So in order to increase his heart rate, I trialed stairs, which got him up to 57% of his heart rate max, which was still not in the target heart rate zone. So I added ankle weights. And this got him up to 68% of his heart rate max, so getting closer to the target heart rate range, but still not quite in it. So here I am going back to a circuit, alternating balance and propulsion, and as you can see, the patient's ataxia is limiting, his ability to really reach those higher intensities. And his heart rate here is 65% of his heart rate max. Here is the actual FITT achieved for this patient. He was seen 1 time a week for 30 minutes. As I described earlier, he had difficulties with transportation. The intensity we achieved was 54 to 68% of his heart rate max, so we were not in the goal heart rate zone. He was seen for 12 weeks, and we did not do high-intensity gait training. We did gait training at low to moderate intensities because we were so limited by his ataxia. And so these were his outcome measures. You can see that his Berg balance score increased by 13 points, meeting the MDC. So even though I didn't do any, traditional like static or dynamic balance training, I incorporated balance challenges into our ambulation activities, and this resulted in transference to improvement in his balance on the Berg, even though that is not an assessment of balance during walking. And so I think this is a good example of that carryover that can be achieved by challenging balance during ambulation. The patient did not improve in his gait speed, and then due to time restraints, the 6-minute walk was not assessed at discharge. So, I think there are a few reasons why this patient had, poor outcomes and didn't respond well to intervention. I think we didn't actually reach the intensity that is necessary. I'm not sure if the frequency we had was enough, and ataxia was really his primary limiting factor. Upon discharge from outpatient physical therapy, this patient was Mod I with stairs, which was an improvement from his evaluation. He was still living in his friend's apartment and receiving assistance from her, so he did not meet his goal to move out. He was issued a rollator and transport chair for use with community mobility. He was also offered a shower chair, but declined the shower chair. This patient was discharged because he was making limited progress with physical therapy, and he felt like it was not worth it to him to continue with intervention and physical therapy, as it was so challenging for him to get to his appointments. Ataxia was a primary limiting factor for this patient's progress. He was not able to achieve the high intensities that I was hoping because the ataxia limited his ability to generate the propulsion to get his cardiovascular intensity into the target heart rate zone. In this case, I prioritized balance over intensity, and I think that this helped improve the patient's safety, but it did not have the same effect as high-intensity gait training may have on patients who are able to achieve those higher intensities, which often requires challenging propulsion, which this patient was limited in due to his ataxia. Upon reflection, there are a few things that may have helped this patient make more progress. The first may be that the dose was not high enough. He was limited in his frequency due to transportation barriers. A higher dose may have resulted in improved outcomes. I also could have trialed using a harness over a treadmill to help him stay safe while he was walking, but increase the intensity and try to reach that higher heart rate zone that I was targeting. So now we've seen one case where the patient had great outcomes with high intensity gait training and one case where we were limited by barriers. So I'll be wrapping up with a final case here. This patient was a 54-year-old male. You can see his past medical history. His stroke was actually a result of complications from his MI. He lived alone in a second-story apartment and worked as a security guard. His stroke was 6 months prior to his outpatient physical therapy, and it involved the left internal capsule and right posterior hippocampus. On initial eval, he presented with right upper and lower extremity spasticity. His right lower extremity strength was grossly 4- out of 5. He reported fatigue in his right and upper and lower extremities, and his balance was impaired. He reported frequent falls and difficulty carrying items up his stairs. He had difficulty with pace and balance during his walking group that he participated in through the VA. He took public transportation and struggled with snowbanks and ice, as well as the stairs to his apartment. He was very embarrassed to carry a single-point cane and was also nervous about using a cane at work and being seen as, weak or incapable as a security guard. He had a lot of social support from his walking group, so that was great, and he walked a lot at work, which was awesome for increasing his stepping. These were his outcome measures at initial eval, 14 on the FGA. Not a big difference between a self-selected and fast walking speeds, and he walked 717 feet with a single-point cane. His goals were to get as much function back as I can and keep up at his walking group. This was the FITT Goal, physical therapy 1 time a week for 30 minutes. Once again, this is lower than the frequency performed in the research, but this was how often the patient was available to come into the clinic. The goal intensity was 70 to 85% of the patient's heart rate max. I was planning to see him for 12 weeks and implementing high-intensity gait training. Barriers to overcome with this patient were falls from walking and using public transportation during the winter. So this was when he was primarily having his falls and loss of balances. And so we issued him an ice gripper for his single-point cane, as well as yak tracks to wear on his shoes for improved traction. This patient was presenting with decreased activity on days when he was off of work. And so on work days, he would achieve 5,000 to 7,000 steps. But on days that he was off, he would frequently only achieve around 3,000. And so he liked tracking his steps on his phone, and he was very motivated by this, Every day at PT, we had to make sure his phone was in his pocket so that he would get credit for his steps. So together we set the goal of achieving more than 4,000 steps each day, especially focusing on those days when he did not have therapy. And then he, as I mentioned, he had trouble with the pace and balance during his walking group, but he was very embarrassed to carry a single point cane. So we tried some trekking poles, and I really sold them to him and explained to him that these were not a cane. They could provide support, but they were not, these are more modern and cool, and he was really into them. He liked it quite a bit. And then this patient also had his gallbladder removed during our plan of care. So we took a 3-week break after the 8th session as he was recovering from surgery, and then resumed high-intensity gait training after that. Here are a few of the walking interventions that I implemented with this patient. In the first clip, he is doing speed challenges, and I've added a 10-pound ankle weight to his lower extremity to increase the intensity. So here he is trying to go faster and beat his previous repetition, and he is walking at 70% of his heart rate max. In this clip, he is trialing the trekking pole. 2 trekking poles were a little bit too challenging for him to sequence, but he did a great job with one and was agreeable to using this device. Heart rate is still at 70% of his heart rate max. In this clip, I have him going up the stairs backwards. So going up the stairs forwards was fairly easy for this patient. I wanted to come up with something that would provide him more challenge. So I'm really focusing on challenging his balance and his limb advancements and propulsion here, all in the backwards direction. And he was at 71% of his heart rate max. In this clip, I gave the patient the cue to skip every other step. This was challenging for him to coordinate at times, especially when he was fatigued. This was a good challenge for propulsion and limb advancement, and you can see that he's reaching 77% of his heart rate max. This is a little bit later in the session where he is more tired and he's having trouble getting that left leg all the way up to skip a step. Here he is descending in the same skip a step pattern, but here I'm having him face the rail and go sideways. Same for ascending. And we did this both with leading with his left lower extremity and his right lower extremity. And we're at 75% of his heart rate max. This was the next session, and I focused on treadmill training. So here I'm having him kick a noodle while he's walking on the treadmill to challenge his limb advancement. He's not holding on to the rails to challenge his balance, and the speed on the treadmill is challenging his propulsion. The harness is here for safety, but it's not providing any body weight support. And in that previous clip, he was at 78% of his heart rate max. Here he's avoiding cards on the treadmill to challenge his balance, and his heart rate is at 76% of his heart rate max. In this clip, he has the cards in his hand, and I've asked him to sort the cards and hand me all of one suit. And so this is a challenging activity for him because it's challenging his balance and requiring him to dual task, which is something that he struggled with. And he's at 87% of his heart rate max. This was his actual FITT. So initially we said we were going to do 1 time a week for 8 to 12 weeks. We did 1 time a week for 9 visits, 2 times a month for 3 visits because he was progressing so well, we decreased the frequency, and each visit was 30 minutes. Our goal intensity was 70 to 85% heart rate max, which we achieved. Initially we said 8 to 12 weeks, but we ended up doing 12 visits over 18 weeks, primarily because he missed a few visits with his gallbladder removal, and we did high intensity gait training. These were his outcome measures. You can see with the FGA, he increased by 10 points, and met the MDC. His gait speed, he met the MCID for both self-selected pace and fast-paced. And on his discharge, we did not do the 6-minute walk because his blood pressure was 185/83, but he had already met the MCID at his reassessment, and so over 1,000 feet, and he had progressed from using a single point cane to no device. At discharge from physical therapy, this patient continued to participate in the walking group through the VA. He liked using his trekking pole because he could carry it in his backpack until he needed it, and when he fatigued, he could get it out and use it to help maintain balance. He was very motivated to keep his step counts increasing, and at discharge was averaging 7,000 steps per day. He also reported improved ease with carrying items up the stairs. This patient was discharged as he has met all of his goals, he had an avenue for continued aerobic exercise, and felt like he was able to manage his exercise routine independently. Despite a lower dosage for this patient, he still had improvements. I think this is a good example of how a frequency that is more attainable in the clinic can still be beneficial for achieving improvements from high-intensity gait training. After reviewing my 3 cases, I'd like to summarize with some final take-home points. To implement high-intensity gait training, it's important to attain and maintain the target heart rate zone. This can be challenging, particularly when targeting balance, and so I find it helpful to implement a circuit that alternates balance challenges and propulsion challenges. It's important that our patients increase their walking outside of therapy. Therapy is maybe only 30 minutes to an hour, maybe 2 per week, and so some strategies that I have found helpful are providing, an app or a pedometer and step goals for the patient, and providing appropriate equipment. So whether that's a trekking pole, walker, yak tracks, whatever they need to safely walk outside of therapy. And then, our patients have lives outside of therapy, and sometimes there's barriers to goal frequency and time. So, if you're not able to get a patient in as often as you would like or for as long as you would like, it's really important to prioritize intensity and stepping during sessions. And so in a 30-minute session, my goal was to always have 22 minutes at least of high-intensity gait training. And so that means, they come in, I get them back on time, do their vitals really quickly, get the wrist monitor on and get going, and minimizing rest breaks during the session, getting a set of vitals at the end, and just, really optimizing stepping. And I was able to achieve good outcomes with 30-minute sessions 1 to 2 times a week. So this doesn't have to be, a daily intervention or at a really, several hours at a time. It is possible to implement high-intensity gait training and get good outcomes with, a relatively standard plan of care. We saw significant improvements in the gait outcomes in cases 1 and 3, but not in the middle case. As I mentioned, I think this is because in the first and third cases, I was able to achieve the intensity for high-intensity gait training. These patients did more walking outside of physical therapy. Essentially, we were able to overcome their barriers, but in case 2, the ataxia was so significant that I wasn't able to overcome that with the implementation of high-intensity gait training. So I think that this combination of cases really show the success that can happen when you are able to increase that intensity and prioritize stepping practice, and what the outcomes are if, unfortunately, due to barriers, you aren't able to achieve those intensities. Thank you very much for watching my presentation. Here are my references for today's talk, and this is my contact information if you have any follow-up questions. Thank you.